All right, guys. Um, Awesome. Hello, it's me. So I wanted to really quickly just go through a very quick uh, just overview of the lecture from this morning. I decided I didn't like the one I did this morning. I thought that it was quite frankly craptastic. So I redid the entire thing. And now I'm recording it for you because I care. So let's go ahead and let's actually just run through really quickly the PowerPoint from today. I've changed it up. I've kind of got some information in there. So I wanted to record this for you to minimize the level of freak out uh, in that regard. So give me just a second here, folks. My bearings straight here. Make sure I'm sharing first of all. Perfect. There we go. All right, backing it on up. Okay, so neurological exam for the elbow. Okay, guys. So a lot of this is obviously, kind of a repeat, but we're doing a bit more of a deep dive here. Ultimately, right, when we talk about the nerves of the upper extremity, right, we're generally breaking these down into three categories: the radial nerve, the ulnar nerve, and the median nerve, right? So the nerves, obviously, both of them have, all three of them rather, have both sensory and motor branches. And so anytime that a nerve, for example, a sensory nerve, okay, that nerve will divide into its branches. And if it's a sensory branch, that sensory branch then goes and plugs into the skin and underlying fascia to provide sensation. That's how it works. Okay. On the other hand, with a motor branch, okay, the nerve will obviously branch off, and then it will actually insert directly into a muscle, right? The point at which a nerve essentially inserts directly into a muscle is called a motor point. Okay, a motor point. And if you guys are in modalities right now, if you have not heard that term, I guarantee you will hear it soon. I know that Mary will teach you guys about motor points, particularly when going over like electrotherapy, those types of things. All right, radial nerve. So the radial nerve, obviously, we know, right, comes off the posterior division of the brachial plexus through the axilla, and enters the elbow actually at the arcade of Froese. Okay, so the radial nerve enters at the arcade of Froese. And so obviously once the radial nerve enters the elbow, it splits and forms both sensory and motor branches. Okay, so clearly sensory aspect, okay, of the radial nerve is going to supply sensation to the dorsal aspect of the hand, thumb, index, and middle fingers. Okay, does not supply sensation to the nail beds. That's median nerve. We'll talk about that in a minute. Okay, so that is the superficial branch of the radial nerve. Okay, so what about the motor branch though? So we can generally divide the radial nerve up into two branches: superficial branch of the radial nerve and the posterior interosseous nerve, and or which is the motor branch of the radial nerve. Okay, the posterior interosseous branch of the radial nerve is going to innervate several different muscles, right? All of them are extensors, like we talked about earlier this morning. Okay, so obviously our extensor carpi ulnaris, extensor, extensor digiti minima, extensor carpi radialis, all of these muscles are innervated by the posterior interosseous nerve. So extensor pollicis brevis, right, the thumb, okay, extensor pollicis longus, and even the supinator, right? So all of those nerves are innervated by the posterior interosseous nerve. There is only one sensory input from the posterior interosseous nerve, and that's actually the wrist joint capsule here. That's the only sensory input to the posterior interosseous nerve. The rest of it is motor. Okay, nearly entirely motor. Okay, so this is actually a dissection of the radial nerve. And what I wanted to show you guys here, so if we look at the letter A, okay, this is the radial nerve coming down. It's got a branch to the brachialis muscle. Okay, now remember, this actually would not be the bicep, because what innervates the bicep? The musculocutaneous nerve. Okay, not not the radial nerve. So letter A here, we see branches going off to the brachialis, okay, over here, letter B. Obviously, these muscles have been dissected out and reflected, but the brachioradialis there, letter C, okay, extensor crapuloradialis longus, okay, and okay, extensor crapuloradialis brevis, it's letter D. Now, here's the deal. Okay, what I want you guys to notice, look at the sensory nerve. Okay, this is the sensory branch of the radial nerve. Okay, and we can see that here, letter E. Notice that it is actually not only much, thinner in diameter than the posterior interosseous nerve, which is letter F down here. Okay, but it's actually also coursing along nearly entirely, in an entirely superficial course along the posterior aspect of the arm. Okay, so posterior interosseous nerve is main motor, and there are many branches that come off the radial nerve to the brachialis, to the brachioradialis, extensor crapulolnaris longus, and brevis. Right, so those are the main motor innervations from the posterior interosseous nerve / radial nerve. Okay, median nerve. All right, so ultimately, this is going to come into the elbow between the peroneal teres and the biceps tendon. Okay, so here. Okay, all right. Now, here's the deal. Okay, it's got sensory and motor aspects. The sensory innervation includes the palmar aspect of the hand. So when I say palmar, palm side, okay, palmar aspect of the hand here. Okay. So the sensory innervation of the lateral palm, supplied by the palmar cutaneous branch. Okay, so now we flip it over. Sensory innervation to the fingers and the nail bed, and the nail bed is supplied by the digitocutaneous branch. Okay, the motor innervation of the median nerve mainly consists of the anterior interosseous nerve as the main motor branch, and that supplies the muscles of the forearm, so the flexor muscles. If you remember, right, that the anterior interosseous nerve is going to supply the flexor muscles of the forearm, you're going to be in good shape. And the branches that come off of the AIN, okay, supply the flexor muscles of the wrist, you're going to be fine. So the recurrent branch of the median nerve innervates the thenar muscles of the hand. So the thenar muscles are here. Remember, radial nerve is only sensory here, right? It's controls extension, right, not flexion. So, but the recurrent branch of the median nerve is going to innervate the thenar muscles of the hand. Okay. All right. Okay. This is a dissection actually of the median nerve. Okay, and we can see how the different branches and muscles that the median nerve innervates. All right, so obviously splits once it enters the elbow at the side of the peroneal teres, innervates the flexor crapuloradialis, palmaris longus, flexor digitorum, and also obviously flexor pollicis as well. One thing I want you guys to see here in this picture on the left, so we actually have the anterior interosseous nerve here. Okay, coming down, and we can see all the branches that it actually gives off in innervating, the flexor crapuloradialis, as well as the flexor digitorum profundus, right, and the flexor pollicis longus, right. So the anterior interosseous nerve, we can see that it's got a really big motor role here. So if we look at this diagram here, okay, this guy out here, the lateral cutaneous nerve of the forearm, okay, this comes from the musculocutaneous nerve. Okay, that is not a contribution from the median nerve or from the radial nerve. Okay, the ulnar nerve, okay, enters the elbow through the arcade of Struthers, like we talked about earlier this morning with my awesome joke. Our kids in the elbow are where nerves go to have a party. So obviously the ulnar nerve is going to provide sensory input into the hand at the dorsal cutaneous branch, right? The palmar cutaneous branch, so ultimately ulnar, okay? We've got, medial aspect of the hand, dorsal aspect here, okay? So medial half of ring and little finger, pinky, right? Palmar cutaneous branch, lateral half of ring and pinky. All right, so There's also the superficial branch, and that's actually also kind of a mixed motor sensory nerve. So it's also going to contribute some sensory input to the palmar aspect of the ring and fingers, but also going to provide a little bit of motor function to the palmaris brevis, which is actually a muscle on the outside of the hand here. You can actually see mine right there as I attempt to kind of flex my pinky down. Okay. Okay, so motor function. All right, from the ulnar nerve. Okay, the flexor digitorum profundus. All right, so my ability to flex my fingers like this. Okay, it's coming from the ulnar nerve. Flexor carpial naris. Okay, my ability to flex my wrist here at the medial half of the forearm. Flexor carpial naris. Now, the ulnar nerve essentially innervates all the hand intrinsics with the exception of a group of muscles that we call the loaf muscles. Okay, so the lateral and brachials. Okay, so lateral is here. So lateral and brachials. Okay, opponent's pollicis, adductor pollicis. So I'm talking about my thumb, right? And flexor pollicis brevis. Those are all innervated by the median nerve. All right, guys. So here's obviously another dissection out of the ulnar nerve. So you can see obviously innervations, and these branches actually are numbered 1, 2, 3, right, 4, and 5. These are actually all different, right, motor points where the branch of the nerve is actually entering into the muscle. So we have the flexor carpial naris here and the flexor digitorum profundus here, okay, that are being innervated by these nerves. Okay, how do we assess function, right, of these nerves? And I know guys that we're beating this horse to death in class, right? But this is such an incredibly valuable skill. It's one that can be difficult, but that's why we're repeating it. So there's 3 main methods that we're going to use to assess this. We're going to practice this in class in the morning. There's 2-point discrimination, right? Assessment for symmetry to light touch bilaterally. So we're looking at light touch, comparing for symmetrical sensation on both sides, and then stereognosis, which we kind of talked about earlier this morning. So with the video that you couldn't hear. So there's that. So a little bit of literature. Let's talk about 2-point discrimination real fast. So there was a systematic review that was actually just done this year, right, that looked at some diagnostic testing for carpal tunnel syndrome. The reason why we chose this, or why I chose this, is because oftentimes, remember, if we're going to do it, we do it distal, right? Okay, we do it distal. So we're going to look at sensory function and motor function at the most distal aspect that we possibly can. So 2-point discrimination, we need to define this, okay, before we practice it. So the threshold, okay, essentially is defined as the smallest gap. And if hopefully we can locate one of these tomorrow morning, but you'll see the pins, okay, on these devices. They are actually spread out at different widths, okay? And so the threshold is essentially the smallest gap in which the patient could identify that there's 2 points. Okay, so we'll ask the patient, do you feel 1 or do you feel 2? And we'll do that at actually different widths. So any normal, right, test and or negative test for 2-point discrimination is going to be intact sensation with any distance less than 6 millimeters, right? So if the patient fails to identify the correct number of points on more than 2 tries, or the distance, right, at which they are able to identify the appropriate number of pins, right, as 1 or 2 is greater than 6 millimeters, that is altered sensation, okay? So those are things that we'll need to keep in mind for tomorrow. All right, so ultimately, let's say, for example, though, that we have a patient that we're looking at, okay, on the sideline. Obviously, the most practical, you're not going to really have a ton of time to check 2-point discrimination on the sideline. But if you're in the ATR, if you're in the clinic, you've got time, and you've got, it's an appropriate environment to be able to check 2-point discrimination. If someone is telling you, for example, that maybe they don't have, that they can't feel you touch, right? And they've got asymmetric sensation, at least that they're reporting, one way that you could actually, use a stereognosis on the sideline is maybe if you have a fanny pack, right? Pull an object out of your fanny pack, right? Whether it maybe is a roll of tape, or maybe it's a pen. maybe it is, a piece of gum and or maybe a little bot, whatever it is, right? Have the patient close their eyes, have them place that object into their hand and ask them what they feel. Okay. Alternatively, another thing that you could do is you could actually place the objects on a table and you could tell the patient, okay, look, I want you to pick up the roll of tape with your hand, right? Close your eyes and pick it up with your hand. And if you see them pick up the roll of tape, instead of maybe using like a pincer grip, like their thumb and finger, like we would normally do to pick something up, if you see that they can't grasp the object or pick it up with that, you know that there's a neurological deficit at the median nerve. Okay. But if, for example, if they're able to grasp that object and they use maybe their pinky finger, right, then you know that ultimately sensory function is potentially intact at the ulnar nerve, but not intact at the median nerve. So that's an example of how you would use stereognosis actually on the sideline and or even clinically. And also obviously having them identify what the object is in their hand. If they can do that, then you know that there is at least some sensation that's present. Obviously, when we look at motor testing, we should know this very well by now, right? All we're doing is checking myotones. Okay, we're just checking myotones, 5, 6, 7, 8, 1. Okay, so there you go, guys. I'm much happier with this now. I wasn't happy with it before, but I'm feel better about it now. I hope this is much more clear for you. And I'll see you guys in the morning. Okay, sleep tight.